Okay, let's take a look at weight management. So anthropometric measures that are going to be assessed are obviously going to be things like height and weight. With height and weight, you can calculate a patient's BMI, body mass index, and we know that that's not a fantastic measure of overall health status. So we want to make sure we take other anthropometric measures that are going to help us determine if we need to intervene or not. So other measures would be things like waist circumference, waist to height ratio, and waist to hip ratio. So if we have multiple measures, multiple assessments that are in the unhealthy range, then we would want to maybe talk to patients about stuff. But if we just have like one that's elevated, like if BMI is high, I'm not going to be too concerned if all of my other assessment measures are going to be fine. If we assess a patient's body composition, we either have lean mass or fat mass. Lean mass is actually a combination of muscle, bone, and fluid. So when we're looking at lean mass lost or retained, a lot of it's going to be more fluid than anything else. Fat mass that can be assessed, it's not just storage, which is usually what we want to get rid of, storage fat, but also we have essential fat, which is required for a bunch of physiological functions. It's required for the central nervous system to continue to function. So it would be like phospholipids and signaling molecules. So we have some that is required. Body compositional measurements can be done using things like a caliper, air displacement like BodPod type of thing, bioelectric impedance, one of those like scales that you can step on and it'll measure relative amounts of lean mass versus fat mass. And then the best measurement is more DEXA than anything else, which is also used to assess bone mineral density as well. There are several different etiologies associated with obesity, not just sedentary lifestyle or overconsumption of nutrients, but even things like stress. Genetics, of course, play a small part. Any obesogens we might be exposed to in the diet or environment. There's sensory-specific satiety, so that's eating the same thing kind of over and over again makes us feel less satiated when we eat it, so we have a tendency to overconsume things. This is kind of the buffet idea. Then we have our gut microbiome. We know that the type of bacteria that we have within the gut will influence how much we're able to harvest, how much energy we can harvest. If we have a lot more fermenters, then we're much more likely to turn those fermentable carbs and proteins into short-chain fatty acids that we can absorb, and we can harvest an extra 150 to 200 calories a day based off of the type of bacteria that we have in the gut. Inflammation is another cause of obesity. With excessive levels of inflammation, it can induce lipoprotein lipase, our storage enzyme. Females have more lipoprotein lipase that's active in the hips and thighs. That's why they're more likely to store more fat tissue there. That'll give us more of the gynoid or the pear shape. Whereas males have more lipoprotein lipase that's more active in the abdomen, which gives them the android or apple shape. All has to do with how active our storage enzyme of lipids is in that particular area. Now, some of our signals for controlling overall food intake is going to be controlled by the hypothalamus. Our main hunger signal is going to be our ghrelin, and our main satiety signal is going to be leptin. Both are going to signal the hypothalamus to either increase or decrease food intake. We have several different things that we can do to kind of try to control some of our food intake, behavior modifications. No suggestions for changing behaviors. There's the ABCs of dietary modification. There's monitoring like journaling. And then there's goal setting. So we want to make sure that these goals are small and able to be monitored and achievable. Make sure they're SMART goals. Some patients can turn to surgical procedures, things like gastric banding, where they put that silicone band over the stomach, which decreases the amount of food that they're going to be able to consume. The most common type of bariatric surgery or gastric bypass type of surgery is called the Roux-en-Y. So with that, they actually cut out most of the stomach and then resect part of the small intestine onto the stomach, which means there's not a lot of digestion that's going to happen within the stomach. We end up with more nutritional deficiencies. Common nutritional deficiencies in patients that have undergone bariatric surgery are things like vitamin D, B12, iron, and calcium. Calcium, iron, and B12 require adequate stomach acid in order for digestion and absorption to occur. And last but not least, we had eating disorders that we had talked about. Some of the most common ones are things where it's severe energy restriction, fear of gaining weight, and they get that downy kind of coating called lanugo on them. That's your anorexic patients. So anorexia nervosa. Patients that have frequent binging and purging episodes, which can also show up as Russell's sign, where they have kind of calluses on their knuckles from recurrent purging, sticking their fingers down their throat. This is called bulimia nervosa. There's restrictive food intake, where they're just very almost anal retentive about the types of foods that they take in. There's pica, which is eating non-food items. The only known deficiency associated with craving non-food items would be ice chips and iron deficiency, but nothing else is typically associated with it. And then with binge eating disorder, this is different from bulimia nervosa because there's no purging. So they eat a lot, they feel guilty about it, but there's no purging episodes. So all of these eating disorders have this very specific diagnostic criteria under the DSM-IV. So these are all mental disorders that if you recognize any of these symptoms or signs in these patients, make sure you refer them out to the correct practitioners.